I'm Ali Foster. I'm the Programme Director for Building Berkshire Together, which is the Royal Berks Hospital Redevelopment Programme. And I'll just introduce the team on tonight. As you know, Charlotte's going to be talking to us in her clinical lead role. Charlotte, I'll let you just introduce yourself.
Hi everyone, good evening. I'm Charlotte Robinson. I'm a consultant radiologist at RBH. I've been at RBH for 13 years. I've previously been clinical director of pathology, and I've got a new, fairly new associate medical director role for Clinical Services Strategy and Building Berkshire Together. I've been working with the team for about 18 months now. I've been on secondment working on some of the clinical model last year, and I'm now hopefully a bit more fixed member of the team. And it's a wonderful team to work with. Thanks, Ali.
Thank you. And Lynn.
Hi everyone, I'm Lynn Bushell. I am Communications and Engagement Lead for Building Berkshire Together. Thank you for joining us this evening.
Okay, thank you. So structure tonight is Charlotte will lead us through a presentation, and you can ask questions, and there'll be a bit of questions Q&A at the end of that. And then when she's finished, if there's any updates or any questions people have, I'm around as well. But and we'll show you a little video. We meant to show it last time, but I don't know what happened. We got carried away with discussions and we didn't show it to you. But anyway, we've got a little video to show you from the new hospital programme that sort of highlights what Hospital 2.0 is intended to be like. So it's only 2 or 3 minutes around what is Hospital 2.0. But I'll hand over to Charlotte now to present this next session.
Thanks, Ali.
Right.
So Lynn's got some slides. So I'm going to give you a bit of an update on what we've been doing from the clinical point of view. Some of you may have seen some of these slides already, but I'll update you on what we've been doing in terms of developing the clinical model over the last year or so. We'll go to the next one. Great. So our clinical services strategy for RBH was launched about 18 months ago, and it's based on delivering the best care that we can deliver, making sure it aligns with our patient needs. Prevention is a really big part of this now, and it's around making sure it's a patient-centered approach, reaching patients where it's best for them. Thank you. Next one. Could you mute people, please, Lynn? Thank you.
Oh, I don't know if I can do both. I will try.
Okay, so what we're really keen to do is make sure that we are looking at patient journeys way more, clinical pathways, treating the patient as an entire entity from when you present to your GP, making sure that we're managing the whole patient pathway better, making sure we're delivering care in the right way, which is much more individualized, really using the power of digital innovation, which is becoming available to us, but will continue to become a really powerful part of the patient journey, and making sure that we're using our workforce in the right way and using highly trained multidisciplinary teams. Thank you. We have to be working a lot better with our community partners. From a patient point of view, I'm absolutely certain it feels very fragmented at the moment in terms of how we deliver care across from seeing your GP to coming to hospital. And we're really keen and really passionate about really developing much better links and teamwork and patient pathways with our community. This is hugely important. And
get me out of here. Final question in the house. What is this?
Making sure we're working better with our community partners. And again, as I said earlier, really working out how we're going to use
Sorry, struggling to.
Sorry, could everybody put their phones on mute or their computers? There's an iPhone just called iPhone that keeps cropping up. So if everyone could go on mute, that would be really helpful.
Thanks, Lynn. We'll go to the next slide. I quite like this picture here, which shows what we're really trying to do in terms of developing our clinical model and how it's going to fit in with our new hospital programme and building our new hospital. We're really beginning to look at how we can deliver acute care on site within an acute setting, but making sure that we're delivering other parts of care in different ways and in different settings. So I think it's a really nice 4-quadrant diagram looking at how we could be working differently. Thank you. Next one. So in terms of developing the clinical model, we've been looking at pathways, we've been looking at activity, and we're trying to link it all together in terms of what equipment we're going to need. How can we digitize and make sure we're using all the technology to the best of our ability? Are we using our workforce to the best of our capability? Looking at what space we need, how we're going to use the space, where we should be delivering certain parts of patient pathway, particularly diagnostics. And all this feeds into the design of the new hospital, very much a collaborative approach, working with our community partners, working with primary care, looking at how we can and really think about how we can deliver clinical care slightly differently in the future. Thank you. So what we've been doing, next slide. We've yeah, we can carry on to the next one, please.
Oh, sorry.
That's all right. So we've been looking at several patient pathways, and we've looked at heart failure, we've looked at falls, we've looked at trauma and orthopedic, musculoskeletal day case, and lower gastrointestinal cancer. And we've looked at some emergency care pathways, particularly breathlessness. And the reason we chose these 5 pathways was because they are big ticket items. Lots of patients come through these pathways. They have a high impact in terms of, if we get these pathways right, we will impact a lot of patients. And we also recognise that the fundamental building blocks of each of these pathways can be transferred to lots of other pathways. So if we get this right, we should be able to then extrapolate that to lots of other clinical pathways. Go to the next one, please. We've had this was end of last year, numerous workshops engaging stakeholders across the patient journey and patient pathway, making sure that we've been working closely with our healthcare planners, stakeholders within Berkshire Healthcare, Berkshire West, and within our integrated care system. And what's been interesting is what's come out from the conversations we've had with staff. And I think these are the 6 key points here. Is that digital, without a really good digital strategy and making sure that we're using digital opportunities as best we can. But that's a really fundamental part to improving some of the patient pathways and clinical model. They need to be based on best practice. And we've really heard that patients are really passionate about developing and providing the best care for patients. And we really need to think much more broader and wider and more aspirational about how we can link the care from the acute hospital setting with the community. Thank you. There's 5 pathways that we developed are still evolving, and they will continue to evolve, but they are really good examples of pathways that we can then transfer to other pathways. And the common themes have come out from working on all of these pathways. It's digital. It's we need a better IT system across the community, across the acute setting, making sure that we've got shared patient records. That's so important for patients. When you turn up in one when you turn up in one healthcare setting and there's no record of what's happened to you at your GP surgery or at another hospital 10 miles down the road. So that's a really important factor for us. The use of the virtual hospital space is something which we are definitely ahead of the curve of in Berkshire in terms of how many patients we deliver care through the virtual hospital. And that's something which is great for patients because it means they don't have to be in an acute setting, but can still continue to have specialist care, but monitored virtually. So that's an area which has been really highlighted as something we should be looking to progress and maximise in the future. And making sure that we're working better with our community partners and keeping patients out of hospital, patients with long-term conditions, making sure that they can access specialist care, but not necessarily in an RG1 setting. And trying to separate the elective work from the non-elective work using community diagnostic hubs and one-stop services. And we can't do any of this without a workforce. And we need to continue to look at different ways to make sure that we can train our workforce, maintain our workforce, and retain them as well. Thank you, Lynn. So this is an example of one of the pathways. This is trauma and orthopedic and musculoskeletal. So this is what happens at the moment. You go and see your GP with knee ache, and your GP will refer you to see the community physio, or will refer you into the acute hospital, where you'll be referred through a multidisciplinary team who will then determine whether you need an operation or you don't need an operation. If they determine that you think you do need an operation, you end up going into a pre-operative pathway, so a pre-op workup. You may need to have an anaesthetic assessment, you may need to have some x-rays, and then you will have your operative procedure, and then you will be discharged after follow-up. So that's currently what happens, and most of the care is happening within the acute hospital setting. So it means you're having to come to RG1, fight through the traffic, fight for a parking space, or you may be being seen, so you're being seen within the acute hospital setting. And that's not necessarily the right place for a lot of these patients on this pathway. We think we could be doing it a lot better. So the next slide shows you our aspirational future day case pathway. So you can see that most of the work will be being done within the community setting. So referrals will come in from the GP and will be seen by a community physio, or FCP is first. It is first. Oh, bear with me a moment.
Contact physio, isn't it?
Thank you. Exactly. Okay. And the physios are a brilliant, absolutely brilliant part of our workforce, particularly within the MSK setting. And they will make sure that the right patient then ends up in front of the surgeon for a potential operation, and the patients who are not suitable or an operation is not the right thing to happen to them will end up being treated in a different way. And a lot of this pathway can be done outside of the acute setting, so it can be done in the community, closer to the patient's home, closer to a setting that will suit patients better potentially. That means they won't be having to drive into the centre of Reading. They could be being seen in West Berkshire or in another space. Also, a lot of this community-based care could also be done virtually or on a digital platform, which may suit some patients more than others. So it's quite aspirational what we're thinking of. It's around making sure that we are delivering care in the right place for the patient, not necessarily on an acute site, and making sure that we're using the right workforce to see the right patients. Thank you. So we'll go on to the next one. I've got another example of some work we did, and this is a cancer diagnostic pathway, and this is for lower gastrointestinal cancer. So this is for colon cancer, essentially. So at the moment, this is what happens. You see on the left here, patients go and see their GP with either a change in bowel habit or some rectal bleeding.
Sorry, is it just me who can just see a blank screen?
Oh, I can. Can you not see the next slide? We're on 14. I can see it. Can you not see it, Ali?
I can see it.
Oh, okay. Must be me. That's fine.
Is there a delay, maybe? Can you see it now, Ali?
No, but that's fine. You carry on. Other people can see it. That's fine.
Okay. Well, that's strange. Okay, so this describes what happens at the moment. So you go into your GP with symptoms that may suggest that you might have a colonic cancer, and the GP will send you into the acute hospital setting on a two-week wait pathway, where you were then triaged, and then you have some diagnostic tests. You will then go back to clinic to get the results of your tests. You will then be discussed in our multidisciplinary team meeting, which happens once a week. And then ongoing management will be planned, discussed, and discussed with the patient. And that's what happens at the moment. And then the next slide shows what we hope will happen in the future. So again, it's the themes are very similar to the previous musculoskeletal pathway I showed you. It's around delivering care closer to patients' homes, out of an acute hospital setting, ideally more community-based, but reaching patients where it's best for them. So it'll be way more of the front end of the pathway delivered in the community outside of the acute hospital. The diagnostic tests don't need to be done in an acute hospital setting. They could be done in a community diagnostic centre, or certainly outside of an acute setting. And then the decision to treat and what happens afterwards will then happen maybe in an acute hospital setting, but again, maybe not. And we can extrapolate this future diagnostic cancer pathway for this body part to other cancer pathways as well. Thank you. So why are we doing all of this? Well, we need to ensure that future healthcare services and healthcare precision is fit for purpose, is fit for our patient population, and involves fundamentally thinking again about how we deliver care outside of an acute hospital setting, making sure that we're working better with our system partners within the community and with our primary care network. So the point of all of this is to build into the new hospital programme, which allows us to think about what space we're going to need for our new hospital and how we're going to design our new hospital. And this is my final slide, and I really like this one. I think I stole this one from you, Ali. I think this is a really beautiful, it's colourful to start with, but I think this is a really lovely depiction of how we are looking to deliver care in the future. It's around the NHS long-term plan. The ICS is the integrated care system, which we're a part of which is Bob. Place is the GPs, is the primary healthcare networks, which is Berkshire West, and linking in with the trust. So it's linking all of this together, really focusing on how we can work differently, particularly around trying to keep patients well and out of hospital. That involves the prevention and management side of things. Planned interventions being elective care, not necessarily needing to be delivered in an acute hospital setting, and making sure that we adapt and we collaborate and work better as a system. So that's it. Thank you. So I think there are a few questions on the chat. I'm seeing John Sharp is saying, there are obvious advantages with distributed functions, but is there not a potential problem with less efficient use of resources, which will require additional staff? i.e. one location is busy and another not sharing of remote resources is more difficult? That's a great question, John. And I think that we will not have a bigger workforce, and we need to be thinking about how we can deliver care in a better way. And it won't be a case of requiring additional staff, because we'll be moving staff between sites, but we'll be delivering care differently in different places. Does that answer your question?
We've got a hand up as well, I think, have we?
Yeah. Where did we go?
Yes.
I don't
Ian.
know who hand up first. Did you see, Lynn? Does it matter?
I can see Ian's hand, so let's go with Ian.
Charlotte, thank you for your presentation. I've got a couple of questions. One relates to the new way of delivering care. You mentioned 2 new pathways. Now, both those pathways seem to me to be moving a lot of care out into the community and delivering the care there, which is laudable. But will there be a transfer of resources from the Royal Berks out into the community to support the diminishing number of GPs that are out there delivering? So that's the first question, because historically that's never happened, certainly in the last 30 years. The second question is, you talk about greater connectivity with the community. And again, I think that's an excellent idea. But one of the biggest difficulties for patients is they cannot find out where they are in the system. It's very difficult to get hold of anyone to discuss. Perhaps they've been referred for an X-ray, a scan, or an outpatient appointment. What are you doing about setting up access for patients to find out where exactly they are in the system? Thank you.
Thank you, Ian. So but your first question is around will there be more resources within the community? So I think it's safe to say that we don't expect our workforce to be expanding. This is around how we can collaborate better and work better with our community partners, and how we can make sure that the right patient is being treated in the right way. When I talk about shifting of care away from acute site, I don't necessarily mean putting more responsibility and more workload onto the GPs at all. That's not what I mean by this. What we mean by this is, how can we work as a system better with patient pathways, making sure we're using our workforce effectively, and providing some of the care that we would have previously provided within an acute hospital setting in a community-based setting, be that having a clinic in a leisure centre or in a community diagnostic centre, or exactly what that looks like is to be determined. And then your second question around knowing where you are as a patient on the journey, I think that's a really, really valuable point. And I think you're absolutely right. It's incredibly difficult to navigate the system as a patient in that. So maybe that's something we should be thinking about in terms of digital connectivity. Should we have an app where you're on a patient pathway and you can see where you are? Say, right, well, I'm waiting for this to happen, and then I'm waiting for that to happen. That's all something we could explore. I don't have a quick answer for you, but that's very helpful feedback to know. And actually, we all know this as patients, and I know this as a patient myself. Sometimes it's incredibly difficult to know what you think is about to happen next, or when you're going to get the results of what happened 2 weeks ago, and how long do you leave it before you chase up somebody to know that it is actually happening or hasn't happened, or how often do you have to nudge through the system? Yeah, that's really helpful feedback. Thank you. Kate,
I think next, Kate, yeah.
Thank you. Yeah, evening, Charlotte. Welcome to the meeting. So I've got a concern because I'm as an advocate for those with disabilities. In your shared care bit, it was whether the trust is sharing with the patient and the so-called advocate or parent carer, or sharing amongst other hospital trusts that patient's currently with, because I'm with Oxford as well as London. So I was just wondering if you're able to make that a bit more clearer.
So, Kate, thank you. Do you mean in terms of shared care records or access?
Exactly, yeah, because when I was rushed into Reading at the end of February, actually on the first day of the doctor's strike, I ended up having to get hold of one of my consultants on his mobile, and he's completely plain and said, "Do you ever need me, you ring me." And I did need him that Saturday, and I rang him and he turned up. I mean, that's complete dedication. I said, "Here are the brains. He knows what to do and everything else." And that was just brilliant, because I've got that capacity and that facility to do that. I've had clients before that have not been happy in an acute setting, in a community setting, because their needs have not been met, as in disability, but had to have then gone back down to Reading to have been met. That's the concern I've got.
Yeah, and it's an absolutely valid concern. It's really difficult. So we have at the moment across the net across Bob, which is a network, we have shared imaging, So if you turn up in Oxford, Oxford can see all your imaging that you've had done in Reading, and vice versa. There is a platform called Connected Care, which is linking up the primary care networks and your GP records.
I wish it would do London because it's doing my head in.
But this is still very much work in progress, and the digital capabilities that we aspire to are definitely a long way off.
It's just trying to be that smart hospital with smart timings, with the smart care to go alongside those three capacities. And obviously, I mean, Lynn, you can vouch for that. You've seen me think on a case, and I've taken off down the hospital corridors. I'm just best left alone because my brain is highly functioning. And you know, I have a disability of my own, but I completely wipe the floor of that and focus on the case in hand. I've had to have support workers ring me up saying that they need to attend a telephone meeting within the site to their offices, and then they will need me to support the client. I'm like, I'm on my way, you just have to give me 25 minutes. And it's the reliability of when the consultants come in, and they're like, well, what are you doing here? I'm like, well, I'm actually an advocate. But you know, I'm then having to change my role completely as to being a patient, because they can suddenly see me as a patient, but they've never seen me as an advocate. So that's why I was thinking about shared care as opposed to the hospital trust, or is it between the patient and the trust, as in their carers or their support workers or necessary key workers, whatever they get called, because it varies throughout the counties.
Thank you.
Thank you.
Can I have a question from Caversham? That'd be all right.
Hello, Caversham. How are you?
It's Sean at Caversham. Right. At the moment, we can walk into the hospital. It's a half-hour walk from Caversham. We don't use any bus. We don't take any car unless somebody's disabled and so on. So our first concern is, if you're going to move away from that site, this is going to increase traffic, car use, need for new bus services, whatever. The second thing is, you're talking quite rightly about decentralising services, distributing them wide. What would this look like from Caversham? At the moment, there's nothing other than GP services in Caversham. So your new distributed system, it sounds a good idea. What would this look like in Caversham?
So I don't know if Ali, you want to come in here. So the next stage of our new hospital programme journey is around doing an impact assessment, and it's looking at the options in terms of if we were to move and if we weren't to move, what it would look like and what that means in terms of patients and delivering services. Ali, did you want to say anything? Or Lynn?
Yeah, I can speak. Is Ali, are you there?
Yeah, so just to expand on the impact assessment. So what we'll be doing, and we're starting in April, is an exercise that looks at the impact on patients and on staff on moving the hospital. So if we move, and there's some sophisticated modelling and data things that you can put in that tells you, you know, who's most affected, where you move it further away. And then we come up with areas where there might be a risk to people of accessing services. So if there's a risk that you don't go to the hospital because you now have to get 3 buses or 2 buses instead of 1, what are the things that are possible and potentially within our gift to be able to mitigate against those? So do we need to put on a special bus service, for example? That's one of the things we might want to consider. What are the parking facilities like? Park and ride facilities as well. So between April and July, we'll be carrying out that assessment, which is done through both looking at the data, but also by talking to different people affected and talking to community groups and community leaders and people who represent various different people in the community to understand a bit more about the impact. So, I mean, the other thing is that and we were just talking about this today, it might tell us that the impact is that you might have to get an extra bus to get into the hospital, but that doesn't tell us whether you will actually do that, because some people don't want to do that or would struggle because has different access to it. So we need to also talk to people about the realities of moving the hospital from where it is now to so it's great that you can walk within half an hour, and it's a great use of that time. There are people at the moment who are, I guess, having to come from different places like West Berkshire, who have to get a bus that only comes by their house twice a day, I guess, to come into the hospital. So we have to just look at the whole population and see who is most affected, and what are the things we can do to ease that, if there are any pain points to ease that to get to the hospital.
Yeah, but why don't you stay in the centre of Reading, where access from the majority of the population is reasonably easy?
Well, I think,
especially if you're distributing many of the services around the periphery, I assume that you would be able to reorganise on the current site, which would save travel for both staff and patients. So
some of the things that we are looking at in terms of moving, particularly for the large population in Reading, is what are the services that population uses most. So it might well be diagnostics or outpatients appointments, or what are the things that population use most, and what can we therefore leave either on our current site or somewhere else in central Reading. So we are looking at those things. We are looking at what we can leave in Reading, particularly for the population of Reading. Absolutely.
Okay. You're travelling around consulting, so my invitation would be, I've no authority to do this, but just to say, come and see what it looks like from Coversham's point of view.
Okay, thank you. And we have done a residents association talk in Caversham last year. Who was that with?
That'll be with Cadra. Would it be?
I think it was Wadra. I think it was Warren. Was it
up at the Warren?
Yeah. We could do a Cadra one for sure.
Well, Warren's a small part of Caversham.
Yeah.
Open to invitations anytime, John.
Right, okay. I'll get our PPG to invite you.
Yep, no problem. No problem. Ian, is that a legacy hand or is it another hand?
Sorry, Alison, it's the legacy hand. I'll take it down.
Okay. Right.
Any other questions? There's some in the chat, a couple in the chat. So, Gay, I'm struggling to understand that that one. Are you talking about private physio when showing side-ish, and was in conjunction with Bob's? Do you want to explain that at all, or?
Might have been this.
Okay. Yeah, so the clinical model, I was just explaining about the clinical model, that it is quite unique to each hospital in terms of how it's delivered and what's prioritized, because it depends on, we've got people who both live in villages and live in high population. Our population is diverse. It may be different to somebody who's a hospital in the centre of London. That's all of the population would be quite urban. And so thinking about how we organise and where we put services is going to be different depending on which hospital you've got and what other services are around that, in terms of specialist services or mental health and community services, those kinds of things. So although we've all got the same standards that we've got to deliver, so in terms of high quality services, how we organise them and where we deliver them tends to be quite unique to most trusts. Candice?
Hi there. This
Hi.
might be the wrong meeting for this because I think in the description it says more about the medical side rather than the building side. I work for Reading College and I was just wondering how we can get the students involved in the actual build of the project.
Oh, okay. Happy to connect with you afterwards and have a discussion. Yeah, let's set up we can easily set up a Teams call, or we can pop down and see you. We're only around the corner. We link at the moment with Reading University and the School of the Built Environment, for example, and support them doing essays and things like that. But also we welcome ideas from that younger population as well, so we're really keen to get those involved. Yeah, so let's have a conversation after that. We'll send you, we've got your email because you signed up, is that right, Lynn?
Right.
Yeah, I'm guessing so, but Candice, I'm just sending you now a contact email address,
Okay.
and perhaps
Right.
we can connect.
Thank you very much.
Okay, good. Ian?
I think we might need to let Charlotte go, Ali, if there's any more
Ah,
questions
okay,
for Charlotte.
yes.
So just wanted
Sorry. Any more?
Hello, I'm Penny. I'm with Ian on this call, and I just wondered if you knew what proportion of your patients arrive by public transport and what proportion arrive by car.
Yeah, we're just doing that data now, so we're just updating it now. So that will be part of the impact assessment. So we're working on that now. So we don't have a definitive figure just at the moment, but we will have it in the next 2 or 3 months.
You were updating it. I mean, what was the previous figures? Did you have those?
I don't have them to hand, but perhaps Lynn, if you could just do an action that we can get that from Travel and Transport. I don't have that with me tonight.
Because I mean, it's fairly critical, isn't it, as to how the decision is based on that sort of information.
Yeah, absolutely. There's quite a high proportion of public transport that come to the hospital at the moment.
Okay, fair enough. Thanks.
Thank you.
Hello, I was just typing, but it's me. Hello. I was just typing a message, but as no one was talking, I thought I would just speak instead. Charlotte mentioned that prevention is part of long-term sort of thinking around future healthcare. I just wondered if, in actual fact, that means it's safe to assume that there would be fewer people in hospital in future. And so perhaps some of the sort of fears around travel to the hospital would actually reduce naturally. I'm not sure if it translates in that way.
Thanks, Bea. I don't think we're there yet to be able to extrapolate it. This is more around making sure that we can keep people well and keep people healthy, and by that we mean mental health, we mean physical health. Allowing people to live longer, live well, and live longer healthily, be that smoking prevention, be that more education around diabetes, be that more education around obesity, preventing long-term conditions which ultimately then affect you later in life.
Thank you.
Cool. No more questions. Is that Ian? Is that another hand for Charlotte, or?
It is actually. I'm sorry to keep asking questions, but I think
that's okay.
So many of the things that are presented raise more questions than answers. I wonder if you could update us on where we are in terms of actually making a decision and actually starting, because it's probably around 3.5 years since the announcement was made of these hospitals. You're doing all these consultations and finding out information, but in 3.5 years they change, and I'm just a little bit concerned that it'll all have to be repeated because it's considered out of date. And I'd also put it in the chat, if you could give us some indication of how much the trust has spent on this project so far, including building Berkshire together. Thank you.
So complicated process. So we came on the program 2019, had to do a strategic outline case, which we submitted in 2020. A strategic outline case involves a lot of financial analysis, designs, architecture, surveys, etc. So that was completed in 2020. While we're doing that locally, there is a national process. So although the program was announced, the funding for the program hadn't been given to the new hospital program, the full funding for the hospitals until May last year. The announcement of the up to 20 billion for the hospital. So although an initial 3 billion was allocated to get people started on the program, the full allocation hadn't been identified until May last year. So they were working on what those costs were over that time period. Over this last year, they have now they know what the allocation is, although they've made the application for that in the previous year. They still have to submit another business case to Treasury that is going to Treasury in April, which outlines the scheduling of schemes and how much schemes will definitely get. So we had an initial allocation given to us in May when we heard about the announcement, but that has had to be tested against what our scheme would be over the course of the last year. So we are in a kind of also a unique position that we, as is known, we have some features on the site that we've been doing some geological surveys across the site to understand the impact of those features. And we also have a very constrained site to deliver the new sizes for the hospital. So Hospital 2.0 is approximately a third bigger. If you were to build the same amount, it's about a third bigger in size. And on our site, there is hardly any room to maneuver that. And we would need to build up. And in our current area, we're in a constrained site. We've got a conservation area and residential area surrounding us. So planning permission for a structure that would build up would be very problematic. We presented this evidence to the new hospital program in December, and they have commissioned an independent report with Mott McDonald's that has been working through from January, February, and is now finishing their report to be submitted at the end of March to review our position on the program in terms of so we were initially funded for the early phases of a redevelopment on the current site, and we presented evidence to show that that would be very problematic and not represent good value for money. They have taken that report and said we need this independently scrutinised and reviewed, which is the right thing to do. And that's what's been going on over the last 2-3 months. And that report is being presented to the new hospital program, and then they will review our funding allocation and our position on the program as to whether we should move off the current site and support the trust position on moving off the current site. And then there has to be a discussion about allocation of funds to align with that decision. So that's another process around increasing our funding from where it is at the moment, because it wouldn't fund an off-site development. And so all of these things take a lot of time and analysis and back and forth to make sure that we're doing the right thing for the population. So as part of the process, we are now having to update some of the information in relation to off-site developments as opposed to just an on-site development, because we think that that's too problematic. So it's been a complicated process. There's been things going on nationally in terms of them trying to actually secure the funding for the program, but also trying to establish standards national, because the new hospital program is about developing a new way of building hospitals, standardized approach, standardized rooms and wards, where things are located, you know, what department next to what department, the best, most efficient use of digital that's also been worked on over the last couple of years at that national level. And locally, we have been assessing and appraising our options, making sure that whatever our allocation is delivers good value for money and delivers what our population needs. So there's been sort of a parallel processes going on. Cost of working all of this out has been at a local level, I estimate somewhere between about £4.5 million over the last 5 years. So delivering the strategic case, a program team that has that multidisciplinary team that's working. So we are only a small part of the team. When we do big chunks of work, we need to bring in architects and surveyors and designers, healthcare planners, cost consultants, a whole gamut of multidisciplinary team. Whenever we do any deep dives, information is required for us to submit on a national level. So it's about, I would say it's about £4.5 million spent.
Thank you. Do you have a best guesstimate of when decisions might be made?
We are hoping two or three things are coming together at what's supposed to happen in this next phase. So the report that the Mott MacDonalds have done is going to be reviewed by the New Hospital Programme in April. And in April, they are submitting the programme business case to Treasury. And that programme business case is asking for more money. So it either will get approval or it won't get approval. And if whatever that allocation is from Treasury, they will then come back and read what the independent report has said, and then present us with either an updated figure or some decision about what our next steps are towards the end of April. So a couple of things are coming together towards the end of April, beginning of May.
Thank you.
Okay.
Do we have a preferred site?
No, we don't have a preferred site. We've got to, again, we've got to do due diligence on them. So we've done desktop due diligence to understand if they're feasible. So on the surface, are they available? There are some checks and balances that we do on a desktop level for a couple of sites, but the criteria survey that we've just closed on, that was asking the public to engage with us about have we got the right criteria looking for sites. Do people might know sites that have that aren't on the market that might have been available. So through that survey, we're just analysing the outputs from that survey now to understand, have we missed anything from a criteria, or have we missed any land opportunities? So there may well be an expansion of the sites available. But at the moment, we've got 2 to 3, 2 very strong, score quite highly, and then there's a third one doesn't score quite as highly, but it has some other issues, but it's still possible, and none of them are favourites. So in order to get to a favourite, we will be doing the impact assessment. So what's the impact on the staff and on the population of moving to either of those sites? And we'll be doing that between now and the end of July. And then there will be a public consultation process linked to any new site, which will probably happen towards the end of this financial year, if not next financial year. So that's quite an involved process.
Will you be looking at the carbon footprint of each site?
We will. That will be part of the assessment process, absolutely.
Because if you go out of town, you're going to create a lot more travel for the people who are in the main population centre. So I'm assuming you will be looking at that for a site that reduces travel and use of cars and so on.
That will all be part of the impact assessment. So we'll have to evaluate that as part of this process that we're going into in the next 4 months.
Great.
Yeah, absolutely. And we'll present that back to you guys. So you know, in about 5 months, 5 or 6 months time, we will do a presentation that says, here's all the things that we looked at and here's the results of those. So we'll present those back to you when we get them in 4 or 5 months time.
Thank you.
Okay. Right, any other questions in the chat? Other confirmation from council officers of the height. We wouldn't get confirmation. We don't get confirmation from officers. You have to get confirmation, you have to go through the planning process. They can give us an indication of some of the issues we may have, such as height factors, but that doesn't mean that it's and we might even test that, but it doesn't mean that they wouldn't make the decision. So the planning committee would make the final decision. They can only give us an indication. So and some challenges that we may have in receiving planning permission for some of the features that some of the buildings that we've suggested we would need in order to remain where we are. So that's that one there for you, John. There are geological features all across Berkshire as a result of Lambeth, London clay. This results in high frequency of sink and swallow holes, so it's not unique to the London Road site. So I don't think it is. I think you're right. It's not unique, and there are chalk mines underneath Reading. It can pose just higher costs, some risks in terms of how we logistically ensure that we sort those out before we build on them. So they wouldn't prevent us from building. It just makes the process of building a bit more complex. So it says there, no, they'll definitely offer advice. I think you're talking about the officers. They've been to the site and they've had a look, and we're in regular discussions with the planning team in Reading. They were, also helping to look at other sites that were in central Reading as well. So we're constantly trying to work with them to see, if there is a solution that would mean that we wouldn't need to move. So we are working quite closely with them on that.
When you're looking at alternative sites, have you got some idea of the number of people who visit the central hospital in a day or a week, either as staff or as patients or as subsidiary support staff, deliveries and so on? That would give you some idea of what's needed in a new site if you were moving to a new site.
Yeah, we do. I mean, I don't have the figures actually to hand. It might be for our next one, we might look at what we do have in terms of activity to the hospital, Lynn, if you wouldn't mind making a note so don't forget. Yeah. So in the next session, we can, these figures will be updated as part of the impact assessment, but it will give you an idea of what we know of the last time we took some of this data. So we've done some work on, we've got staff coming in different shifts, and we've got visitors, we've got businesses who come in, we've got, patients who come in for appointments. So it's an extremely busy site. Absolutely. We've got some figures, but I'd be guessing if I was to try and say what they are now. But we can do that for the next one. We can share what we've got for the next session in a month's time.
That would be helpful because if you're going to a new site, the effect affects everybody. It affects staff who are travelling from home. It affects people who can walk or cycle or whatever. And I think, if you look at a new site, you've got to have an idea of the totality of the impact on that site, which as it is at the moment, it's city centre, so a lot of it is sort of not evident that it's a major problem. But I suspect maybe some of the alternative sites, the existence of a very large business with vast numbers of people coming and going, etc., would have a major effect on that area.
Yeah. Well, let's bring that to the next one. Another thing we might want to do is maybe get in touch with somebody who's done this before. So I remember years ago when I worked in Norwich. So Norwich had a central hospital, and it moved it to the outskirts of Norwich. So learning from what other hospitals have done. So we might see if we can get a speaker to come in one of these and just tell us a bit more about what they did and the implications for that and how they overcome some of those issues.
That's brilliant. So we can do that.
Yeah, let's look into doing that.